Good afternoon. Is it 1 o'clock in the afternoon? I think it's afternoon. Good afternoon, everybody who's here in my Facebook group. I try to do a Wednesday live covering a topic that's giving you some kind of gist that you want to know a bit more about. And for the last couple of weeks, because I've been out doing all sorts of other training, I haven't been able to do a lunchtime live. And today I'm doing a lunchtime live slightly later because I'm in the UK and Dr. Ferhat Uddin, who is my guest today. Where are you, Ferhat?
I'm in Hong Kong. I am the other side of the globe at the moment.
And the curtains are drawn behind you and it's dark and it's night time. And it's time to snuggle down and put your PJs on, I think. So thank you for giving up your evening and coming.
No, not at all. Thanks for having me.
To have this chat with me. So each week I try and listen to the questions that I'm hearing, either when I'm out and talking to people or people are emailing me. And one of the questions that came up time and time again, it was 3 weeks ago, but because I was in front of so many women in a week, because it was World Menopause Week, Ferhat, was this question about bleeding, uncontrollable, heavy, painful bleeding, that people were saying, what do I do about it? And I messaged you, didn't I, Dr. Ferhat, and said, I think we really need to talk about this. And whilst I can give the sort of the fitness and the lifestyle and just some sensible tips, sometimes that's not going to cut the mustard, as it were. They do need to be able to talk to somebody who knows a little bit more, and perhaps some kind of medications might help. And you very kindly agreed to come along and have a chat about this. So I'm going to start by let's just set the ground rules, because some of the people watching this may be completely new to this arena and really not know very much about it. So my first question is, why do our periods change in perimenopause?
So yeah, it's a big topic and it's a really important one. And I think, we always talk about the other symptoms and we don't focus on the bleeding so much. But it's all down to exactly the same reason we get the symptoms. It's because we are ending that stage where we're not producing as many eggs, we're not ovulating as frequently, so that those anovulatory cycles do actually mean that the lining of our wombs starts to thicken up, and we will then have often the most horrendous bleeds. So that can be, like you said, heavier, that can be more painful, they can last longer, they can be more clotty. So we've just lost that natural rhythm that we would have had when we are ovulating every month.
Yeah.
The simple thing is the system's just gone a bit skewed.
Yeah, so all a bit skewed, right? Okay. One of the questions that I've been asked is, I've always had fairly light periods. Does that mean that as I enter perimenopause, that's going to be the same? And I guess conversely, I've always had terrible periods. Does that mean that by perimenopause, I'm going to have really, really heavy flow? Does one necessarily lead to that?
No, there's no rhyme or reason why certain things happen the way they do. So we will see women whose periods change completely and some who they don't. They actually just sail through. For instance, there are some women who will have really regular periods until that point of menopause, and then they just stop. And those are the lucky ones. But majority of women will see a change. And sometimes that's, and definitely early perimenopause, what we see is that the cycles become longer. So it might not be erratic, but there's that slight shift. Yeah. And then they start to become more erratic, and that's when the periods might change. Mm-hmm. There are a few things that will probably predispose women to heavier periods. Weight is a big one. So if you are over
too much weight, Yep.
you are likely to then go on to have heavier periods. Mm-hmm. Diabetes is a risk factor for heavy periods. Polycystic ovary syndrome, these women will probably be used to having heavier periods because they will often have had erratic, infrequent bleeds, and when they bleed, it's often been quite heavy. Yeah. So those are the groups of women where we can almost predict that, when they come and see me, I can almost predict they're going to say they've got heavy periods. Mm-hmm. But again, I've seen women who are thin, who are normal BMI, who don't have diabetes, who come and they have heavy periods too. It's all a bit of a mix.
Yeah, absolutely. I've got a few more questions, but when I asked people to tell me what their experience is, generally it's been, I'm 52, my periods have always been fairly regular, and over the last 12 months or so they've been all over the place. I never know whether I'm going to need to change when I'm out. I never know when it's going to come on. There appears to be no warning. I've got big heavy clots coming out, and sometimes that gives me terrible abdominal cramps and diarrhea going on with it. And I've gone back to feeling like I did when I was a teenager again, unsure about what to wear. And it's the same common theme. It's this sort of irregular, not knowing when it's going to happen. So not only is it irregular, it seems to spontaneously arise, and it clearly gives people a lot of worries. I do remember teaching a fitness class myself a few years back, and a lady was in the class and she suddenly started bleeding, and that's acutely embarrassing in a situation where you're not really wearing clothes that hide anything like that. So it does then have a knock-on effect, doesn't it, on what people are prepared to do. Okay, that's it, I'm not going to go to classes anymore because I'm too worried about what might happen. It's a big problem. So let's split it into two areas. There's what somebody can do for themselves, and then when they've exhausted all of those issues, then they might come and talk to somebody like you. So what sort of self-care tips would you advise that women start with initially before they then think, right, I need some more support?
So it's just being prepared. So like you said, you don't want to get caught short. You want to always make sure that you've got, this time of life, you need a supply, you need something in your handbag in case. And there are over-the-counter stuff that you can buy. And I think more probably for painful periods.
Right.
And a really simple thing that's on the NICE guidelines for painful periods is just to take ibuprofen, but at the higher doses. And I would say start that early, even if you don't have pain on day one, it's preempting it. Just start it early. And that can also help with, sometimes it help with pain down the line if you start early. But the heavy periods, really, I would say seek help. Because you don't have to suffer it. It's amazing the number of women that I see who have just struggled along for months or sometimes a year or more. And there are some really, really simple treatments out there. So my advice would be actually see your GP and see them sooner rather than later.
You mentioned the higher dose of ibuprofen. A lot of the people that I come across don't want to take any kind of medication at all, let alone we use this word higher dose. What would you say is the dose for if somebody was going to take a higher dose to keep on top of the pain? It's like we don't want to chase the pain, do we? You want to get in quick. What's higher dose in your opinion?
So 200 is fine to start with, but some women will need the 400, and you take it 3 times a day, and you can take paracetamol alongside. And I think actually to start with that, it is the bare minimum, really, the 200 3 times a day, and your paracetamol in between 4 times a day. And the Nurofen will work. The ibuprofen does target period pain more. There's another one called mefenamic acid. You can buy that over the counter, but it is quite expensive. You probably want to get that from your GP as well. And that can stem bleeding a little bit as well. So it's a good one. And you can get that over the counter. And that comes in the dose that says on the box.
And at what point are we worried about the, I know I'm going to ask you about what you might do as a doctor, and we haven't got to that yet, but at what point are we worried about this blood loss and our anemia or our hemoglobin levels, our iron levels going down? At what point would we say, actually, that's too much bleeding, we need to keep on top of it?
I think if you're at the point where you are having to change your sanitary use every hour or two, you're losing a lot of blood. And even if that's for 2 days, that's a lot of blood to be losing if you're having to change it that often. If you're having accidents, if you're bleeding through, frequently, that's a big amount of blood loss. So I think that definitely I would do a blood test if someone came to see me describing that kind of a flow. And it might just be mild anemia, but it's something you want to tackle. It's something you're going to feel tired. You're going to also, especially, I know that a lot of us are menopausal, we're going to exacerbate our symptoms if our iron levels are low. So it's something you want to target early. It's amazing. Lots of women who come to me, they're like, I'm losing my hair. And yes, loss of estrogen can cause that. But the most common reason I see is anemia due to high blood loss. And that's what causes the hair loss at this time of life for most women. Yeah. So early. And if your GP doesn't suggest it, you suggest it. You know, I'd like a blood test.
Yeah.
Because heavy periods, it's on the NICE guidelines. One of the things we should be testing is your blood count and possibly a thyroid function as well, if there's been a change.
So I think that one of the reasons why people have said to me they're too nervous to go to their doctor when they've been struggling with this is because that happened to their mum, and their mum had to have a hysterectomy. There was no option, and I think possibly many of us have got parents who are at the age where doctor knew best. Doctor told you what they would do. It wasn't advocating for your own health. It wasn't this sort of transactional relationship, which would be so nice, or is so nice now when you've got somebody you can trust. It was, you go and ask about this and bang, you're in hospital and it's a hysterectomy. So what other things could you try with somebody who's really struggling with this amount of blood loss? What would be your first attack?
So we have a ladder now of treatment. So we would start on the lowest ring of the ladder and work our way up.
Right.
And the first thing that I always do is something called tranexamic acid.
Yeah.
And this is something when I speak to women that come and see me, they've often already tried. And they'll say, yeah, we tried it. It didn't really stem the bleeding. And then we delve a bit deeper and they've just not tried the right dose. And the number of times GPs will just prescribe 500 milligrams 3 times a day, that would do nothing. You need good doses of tranexamic acid. Tranexamic acid isn't a hormone. It's a drug. It's similar to your ibuprofens. It's that class of drug. And it really does stem your bleeding. So you need a good.
How does it do that then? How does it work?
It impacts the vessels around your uterus. I mean, I don't know the exact science behind it, but what we know is that it works very quickly, and you will get an immediate reduction in your blood flow. But you need big doses. So that's 1 gram at least 3 times a day. Start early. Start as soon as your bleeding starts. Don't wait for it to get heavy. And some women we give 1.5 grams 3 times a day, and that's safe. It's a very safe drug. And you do that for at least 4 days, and then you taper off. So then you would maybe use a bit less for the rest of your period, but for 4 days at least, that's what I'd recommend. And it's a really good drug. Before we get onto the hormones, before we get onto other things, it's a really simple thing.
Right. So if this is an ongoing issue, your periods aren't perhaps every month now, they're every 8 weeks or every 12 weeks. This is a way of you controlling that blood flow, and you can continue using that every time you have a bleed. There's no safety issues.
There is no safety issues. There are no contraindications, apart from maybe, rare ones. So like if you've got a current blood clot, but you wouldn't be having it prescribed. It's a very safe drug to use. But you do need a prescription for it.
And what's next on your ladder if that's not doing the trick?
So then it would be a chat about hormones. So obviously we talked about how this is a stage of life where our hormones are out of whack, and that's what's causing it at midlife. So we would be looking at stabilizing your hormones. And there are ways to do that. There are continuous methods. There are hormones that we give when you're having your period. It may be that you're on HRT. And again, that's a completely different direction of treatment, because we would have to tweak your HRT. We would give you, and it comes down to progesterone. That's the hormone that really is the one that's going to stabilize your womb lining. So we would either introduce some progesterone, we would either change the progesterone if you're already on it, and we would talk to you about the Mirena coil, because that's the other way of getting progesterone into the womb. And it's a really good method to stem bleeding.
So you're not of the opinion, this is just to reassure people, that as soon as you go in and have this chat, we're going to be talking about surgery and these sort of drastic drastic actions.
Absolutely not. So, I mean, I think if that's your fear, definitely rethink it. We actually don't have the resources. We know we have really long waiting lists. So if anything, GPs are under pressure not to refer people at the moment. And yes, surgery is on the list. It's right at the top of the ladder. But before that, there's also something called an ablation, which a lot of women would have heard about, which is, it's a day case. It's not something that's, you know, obviously it's still invasive, but it's not, it's changed. What we do now is so much easier than it ever used to be. You'll go in, it's a day case, you'll come out the same day with an ablation. The caveat with that,
tidy up the sort of cupboard, isn't it? An ablation, really.
Yeah, absolutely. It's literally, it's just getting rid of that cumbersome womb lining that is, you know, causing all the problems. And then it will just leave it. It will literally zap the lining and leave you with a really thin endometrium or lining of the womb. And yeah, I mean, the only caveat with that is, you know, you must have had all your children by then and not want to have any more. And obviously there are some women in this group who might still be thinking,
yeah, absolutely,
I don't know, early perimenopause. Yeah. So that's the only caveat I would say. But other than that, it's a really good method as well.
Okay. And then one final thing, and I think it would be very wrong of us not to mention this. People often say, oh, I've been on HRT full time rather than a cyclical HRT. And yeah, I have a bit of bleeding every now and again. I think it's really important, isn't it, for us to confirm that if somebody is on HRT and they are still having bleeding, it does need to be looked at, because if you're on a cyclical dose, then that's slightly different. But if you haven't had a proper period, but you're having bleeding, it's an indication that there's something that needs to be checked out.
Absolutely. And I should have mentioned at the beginning, before we would even go down treatment, we would talk about, do we need to investigate the bleeding first? So even if you're not on HRT, if your periods, and it would really depend on your risk factors, how heavy the bleeding is. And I mentioned, you know, if you're diabetic, if you had PCOS, if you were overweight, those are risk factors for endometrial cancer. And it's something we would need to talk about, think about, do we need to get a scan done first before going down the treatment route or alongside the treatment route? And yeah, absolutely right. With HRT, if you are on continuous HRT, which is the no break, not the sequential, we do expect some bleeding in the first 6 months. It's not unusual, but after that, if you're still having bleeding, or if you have no bleeds for 6 months and then you suddenly have bleeding again, those are indications that we really need to be referring you for hysteroscopy to check your womb lining.
And it all happens very quickly, doesn't it? It's you know, let's get this checked out. You're in that sort of situation. You're not sitting on a waiting list for months or years. It's a weeks. Let's get you checked out so that we can make sure there's nothing going wrong. There was one question that came up in the Facebook group, and I promised I would put this to you. It's got two halves, actually. My main question would be around management. I'm on Neristerone to stop the flooding. Tranexamic acid doesn't touch it. How long should we expect this to last? And she's put brackets, possibly impossible to answer. You know, is there an end game that we might be expecting here, or is this different for everybody?
Yeah, it's tricky. Perimenopause lasts on average for 7 years. So that's the period.
That's a very reassuring word, is it?
Not. Tends to be heavier at the latter end of perimenopause. So I'm hoping, it's really difficult to say without having spoken to you and knowing how long this has been going on for, what your other symptoms were to start with. But if you can sometimes tell if you're nearing the end of perimenopause, you can see that finishing line. It can last for years. But it doesn't have to be, and it definitely doesn't have to be heavy bleeding, flooding for years. And I would say if that northeastern isn't working for you, I would personally want to discuss the Mirena as the next step.
Absolutely.
And maybe alternatives.
She's gone on to say, does the heavier flooding periods mean you are near the end of perimenopause, or am I just wishing? And you've confirmed that it may be. Yeah.
It may be. Yeah, absolutely. It's usually heavier to the end of perimenopause, for sure.
Brilliant. Well, thank you very much for coming and sharing your wisdom with us today. That was really useful. I know a lot of people were not able to watch this live. And I've said, it's never a situation in these online things where anybody can give individual advice. But sometimes people have got a nagging question and they just wanted to ask somebody. And I think you've been really reassuring and helpful and clear today in giving us those answers. Thank you very much. We've got another intention to do another one of these lives in a month or so, where we're going to talk about how do you know when to come off birth control? This is another big question. So I know I'm in the perimenopause. I've been taking some kind of birth control. At what point do I come off and see what's going to happen? So that's going to be our next chat together, isn't it?
It is indeed.
Brilliant. Thank you very much for joining us, everybody. Thank you very much for watching. Do pop any questions in the chat if you've got any, and I will try and answer you. And if I can't answer you, I will ping a message over and see if I can get an answer. But we look forward to seeing you again very soon. Have a good day, everybody. Bye.